Welcome to our channel Medicine A to Z. Today we are going to discuss management of non-STEMI MI, unstable angina versus non-STEMI MI. What is the difference? In unstable angina, as you can see in this picture, there is a minimal occlusion of the coronary arteries which giving rise to ischemia of a certain part of the muscle. Whereas in non-STEMI MI, there is a severe occlusions of the coronary arteries which give rise to necrosis and ultimately ST depression in the ECG. Because of that, in unstable angina, there is no elevation in troponin levels. Electrocardiogram changes may or may not be present, such as ST segment depression, transient elevation, or new T wave inversions. On the other hand, non-ST elevation myocardial infarction diagnosed in patients who exhibit the same ischemic symptoms as those with the unstable angina, but troponin levels are elevated, indicating the myocardial injury. If we summarize the differences between unstable angina and non-STEMI MI, in unstable angina, there's only a myocardial ischemia but no infarction. In contrast, non-STEMI MI, there is a subendocardial infarction. When you take ECG in unstable angina, ECG can be normal or there can be a T wave inversion. But in non-ST elevation MI, ST segment depression is a main feature of non-ST elevation MI. When you go to the troponin levels, unstable angina can be normal or slightly elevated, whereas in non-ST elevation MI, always troponin levels are elevated. But both of these conditions are due to partial occlusion of the artery, but non-ST elevation MI, that occlusion is somewhat severe compared to the unstable angina. But if you take ST elevation MI, that is due to the total occlusion of the artery. When you come to the goal of management in non-ST elevation MI, there are several main goals that we have to achieve while treating a patient with the non-ST elevation MI. First of all, the main thing is we have to alleviate the ischemic pain. Then you have to check the hemodynamic status of the patient, including the hypertension, tachycardia or arrhythmias, and it is not stable, you have to correct it. Third goal of management is very important. That is, you have to choose or you have to select what are you going to do with this patient. That means, are you going to do an invasive strategy or conservative medical therapy? That is very important in managing a non-ST elevation MI patient. Thereafter, main goal of treatment is starting antithrombotic therapy. Antithrombotic therapy include antiplatelet therapy and anticoagulation. The last goal is to start beta blockers to prevent recurrent ischemia and dangerous ventricular arrhythmias if there's no contraindication. What are the steps in initial medical therapy? When you get a patient with chest pain, we normally put him on oxygen. Is it correct? New recommendation is to give oxygen when the saturation is less than 94%. Because if you provide oxygen to an individual with normal oxygen levels, can lead to hyperoxia. Hyperoxia can directly cause the vasoconstriction in coronary arteries. So always put him on oxygen if the saturation is less than 94%. When it comes to statin therapy, high intensity statins therapy is advised for all patients with acute coronary syndrome. Dosage can be around 80 daily when you use atorvastatin, or it can be 40 to 20 milligrams if you use rosuvastatin. These recommendations applies regardless of the patient's baseline low density lipoprotein cholesterol levels. So it is advised to give as early as possible. When it comes to nitroglycerin, we usually use sublingual tablets. We can give up to 3 tablets, but even after that, if the pain is persisting, you can go for intravenous nitroglycerin therapy. If the patient is having hypertension or heart failure, even without a pain, you can go for IV nitroglycerin. You should be cautious when you are giving nitroglycerin if there is a risk of low blood pressure, which can occur with right ventricular infarctions or in severe aortic stenosis. You should be inquire about the use of drugs for erectile dysfunctions within the last 24 hours. If the patient has taken that kind of drug, such as phosphodiesterase inhibitors, better to avoid nitroglycerin as it can cause profound hypotension. When it comes to antiplatelet therapy, if there's no absolute contraindication, dual antiplatelet therapy is indicated in all patients with non-ST elevation acute coronary syndrome. It should be include aspirin and platelet P2Y12 receptor blockers like clopidogrel. When it comes to morphine, IV morphine always reserved for the patient experiencing very severe pain. Normal morphine dosage started with 2 to 4 milligram initial dose, followed by 2 to 8 milligram every 5 to 15 minutes. But large retrospective studies suggest that the morphine use is linked with worse outcome. So liberal use of morphine is not advised. Beta blockers are indicated within first 24 hours if there is no absolute contraindication to reduce the ischemic attacks and to prevent life-threatening arrhythmias. Anticoagulation therapy. For individuals experiencing non-ST elevation MI acute coronary syndrome, it is strongly advised to initiate anticoagulation therapy instead of opting for non-anticoagulation. Anticoagulation should commence promptly following diagnosis and should be administered alongside with the antiplatelet therapy. After the initial medical therapy, revascularization is the mainstay of management in non-ST elevation myocardial infarction. If you take the patients with non-ST elevation acute coronary syndrome, which include non-ST elevation myocardial infarction and unstable angina, typically undergoes either invasive coronary angiography directly or stress or anatomical imaging followed by invasive coronary angiography if there is an indication. We will discuss this in details later. STEMI risk score. There are several scores to predict the outcome of a patient with a non-ST elevation or unstable angina. When it comes to STEMI risk score, it is composed of 7 variables. Each factor present was assigned a value of 1, while absence of the factor was assigned a value of 0. If the score is 0 to 2, it is considered as low risk. If the score is 3 to 4, it is considered as intermediate risk, and if the score is 5 to 7, it is considered as high risk. These are the variables: age more than 65 years, second, presence of at least 3 risk factors for the coronary heart disease such as hypertension, diabetic, dyslipidemia, smoking, or positive family history of early MI. Third, prior coronary stenosis of more than 50%. Fourth, presence of ST segment deviation on admission in ECG. Fifth, at least 2 anginal episodes prior within 24 hours. Sixth, elevated serum cardiac biomarkers. Seventh and last, use of aspirin in prior 7 days. This is the summary of revascularization in non-ST elevation acute coronary syndrome. When you have a patient with acute coronary syndrome, ECG, if there are ST elevations, you will diagnose straightly ST elevation MI, and the management we discussed previously in a separate video. When it comes to non-ST elevation acute coronary syndrome, we will see whether there's ST depression, and followed by if there's elevated troponin levels, we will diagnose it as non-ST elevation myocardial infarction. If there's no T-wave depression and there can be T-wave inversions with normal troponin level, we will diagnose it as unstable angina. When it comes to non-ST elevation MI, we will start anticoagulation straight. Thereafter, we should look for the condition of the patient. That means you have to see whether there's hemodynamical stability or arrhythmia, or whether there's a newly onset heart failure or the left ventricular dysfunction, or if there's a persistent angina or ST depressions following the optimum management, or whether there's any mechanical complications of myocardial infarction. If any of those present, we have to go for immediate invasive coronary angiogram. If all of them are not there, we can wait. You should do the coronary angiogram as soon as possible, preferably before discharge. When it comes to unstable angina, we should look for coronary artery disease with the imaging studies or stress studies. If imaging or stress studies suggest coronary artery disease, we should go for angiogram. This is the summary of revascularization and the timing of angiogram.
Stay updated with the latest in medicine. Subscribe to our channel for comprehensive videos covering the latest updates in the field.